Today's conversation is going to be focused on what we call the new economics of the industry. This has been a topic of ebbed and flowed debate and discussion for many years. The pressures around pricing and patient access and affordability that are both U.S. and global phenomenons that in many ways feel like they're coming to a head and have arrived in the realities of how we do business. And so this conversation will be an exploration of that topic, the realities of how it operates today, what we think is coming, what it means for patients, providers, and our part of the ecosystem here on the manufacturer side of the business. I'm very grateful to have Scott. And Scott, thanks for being here today.
And I'm glad to join you for the conversation today on some topics, as you know, that I think are really important for all of us. I'm currently the Chief Strategy Officer for the pharmaceutical business in the U.S. At Novartis, and in that role, helping to lead a commercial model transformation. I started my career as a physician. I was a general internist. I worked in clinical medicine for about a decade. And what struck me in the practice of medicine, Ray, was how much the way things were regulated and the way they were financed and reimbursed determined what got done. And moreover, how too frequently those things weren't well aligned in the best interests of patient care.
My personal reflection on the industry is, and I'm interested if you feel this way, but 5, 6, 7 years ago, this was a big topic. And the consequence at a very generalized level was a replenishment and a shift of the pipelines, the much aligned, topic of the shift to specialty, right? And for a period of time, the topic on the economic model, the pricing pressures, the patient access pressures kind of got quiet as pipelines were replenished. And we saw oncology become dominant, immunology, rare diseases, and a number of other areas. And frankly, the regulatory view of the world would suggest that was all very successful. We've had double the number of U.S. approvals for new molecular entities the past 6 years than we did the 5 years prior to that. Almost 60 assets a year are being approved. And yet the commercial success is not innately following those approvals. For me, the time now is most relevant because we kind of made a big bet on the pipelines, and now the industry is facing the reality that this is a new economic environment. And I guess my kind of first thought and question for you is, do you think this new economic reality is truly here now? It was talked about as a future phenomenon before. And then part of that, maybe the second part of that is, let's say, how did we get here?
It is quite a paradox, really, what's been going on in our industry over the last few years. On the one hand, the science has never been better, and the insights and the technologies to pursue areas in specialty conditions, in oncology, and rare and orphan and cell and gene and all those things is just remarkable, never been better. And it's clear the capital markets are showing, very substantial willingness to invest in those things. And though at the same time, as you say, it is also true, it has never been harder to put the business together here in the U.S. and I would say, by extension, actually globally as well. It's all of healthcare, but in that the way we, finance and reimburse and regulate and all those things. We've landed in a system where we are, I'll say, as a system that we characterize as the war of all against all. It's a system that does in fact, it actually encourages higher list prices for manufacturers, not lower. And then, as you know, there are large hidden rebates that go back, but unfortunately not back to the patients generally that are using the medicines. And then despite that, very substantial utilization management, lots and lots of formulary exclusion, ubiquitous use of prior authorizations, many step edits, and high patient cost shares as well. The manufacturers know this is all coming, certainly at this point, and they have, as you know, stood up a variety of support mechanisms to help practices and patients navigate their insurance and their prior authorization or get a copay card or whatever it may be. Those things are expensive, but the expense is just, wrapped back into the price of either that product or the next launch or whatever it might be. And so we've got this high friction, high cost war of all against all that results actually, I believe, in higher list prices and harder access for patients. And really what we want as Americans and as citizens, as consumers of healthcare, is just the opposite. We'd like to have a system that encourages lower prices, fair prices, and then when you get them, great access to the medicines. And then to your question about how do we get here, I think it's primarily two main drivers. The first is genericization. If you go back to the late 90s, early 2000s, half or more of the prescriptions that were being filled with branded medicines, and the revenues, the margins on those medicines would go back to support the innovative companies. Those conditions were generally the big primary care conditions, hypertension, diabetes, cholesterol, and so on. Tens of millions of Americans in each of those conditions. So large populations, and the costs then could be spread across large numbers of patients, and therefore the per unit price could be quite low. And as those categories became more competitive, and as they started to go generic, and as the science developed, as you know, the research and development started to shift, and to shift to more to the specialty oncology, rare diseases, and so on. And so today, now 90% of prescriptions filled in the US are with generic medicine. So it's only 10% of prescriptions that are filled that are driving the revenue to go back and fund innovation for the future. And within that 10%, more than half the dollars now are coming from specialty oncology, rare diseases, and so on. So even very small populations. And so we're funding all this future innovation really through the revenues from a very small number set of patients. And that's created the paradox. Once you have that low numbers of patients, high unit prices, it gives a huge incentive for the payer and the PBM to step in and do the aggressive management, which is what they've done, and the extension of which has landed us where we are.
And it leads me to a kind of a big question that's on my mind, and one that I have a conversation with folks about often, is this question of, is anything immune? The response to this phenomenon has historically been defined, as you call it, more targeted areas with smaller populations. But increasingly, even areas like the PD-1 space are seeing entrants come in, signaling that this will be a cost-driven environment in the not too distant future. And so I guess I'd love your thoughts on, do we think that the strategy of shifting the portfolio, being at the forefront of science, makes organizations immune to this phenomenon, or heavily protected from it, or not?
More broadly is you're begging the question of, how much does the great science help any longer? And I do still believe that, of course, it still helps, but sometimes by itself, it isn't enough. What we're seeing in our analyses for new products and for BD&L kinds of targets and those kinds of things, Ray, is increasingly molecules that are great medicines are not necessarily great products. They don't necessarily, to your point, make a great business. And it's a function of this shift in the development from all the companies, the therapeutic area overlap, the competition, and so on. And so now, I think to be successful, you really do need to skate out ahead of where the competition is, or you need to have focused scale in your portfolio. So if you're going to be in a competitive space, you've got more than one product, and ideally you've got great products that everyone wants and needs that can help pull along some of the other parts of your portfolio. Unfortunately, there are some unintended side effects of all of this. And that is that increasingly, as the R&D shifts to specialty oncology, rare, cell, and gene, we're giving up on turning our backs on some of the development of drugs that could still occur in the chronic care conditions. It's the path that we all saw happen with antibiotics over the past couple of decades. When those markets got hard and companies, kind of walked away and started focusing on other things, is now happening in some of the chronic care conditions, including, I believe, importantly, in cardiovascular diseases as a good example. Cardiovascular disease is, our nation's #1 killer. It's the leading cause of U.S. deaths, in normal years, about a third of all total deaths. And that said, between 1990 and 2012, we had a 1/3 decrease in investments in phase 1 studies. From 2000 to 2009, we had then resulting in a 1/3 decrease in FDA approvals of cardiovascular medicines. And then more recently, from 2012 to 17, cardiovascular drugs launches dropped from a total of 13% of the total basket per year to less than half of that, 6% now, which I worry about, as a general internist, primary care physician, and just as a citizen knowing the disease burden. So the great science does help, but not as much as it used to. And the shift to the smaller populations comes at the price of deprioritizing some chronic care conditions.
Yeah, it's a tough reality. It's really fascinating data you share. I think it's also a very kind of patient-oriented point of view. And I think one of the things that we're talking a lot about is the impact to our industry and as owner operators of our businesses, the industry. But I know one of the things that you have talked a lot about, have published on, have researched personally, has to do with the impact of all this on patients, the practice of medicine. Can you talk a little bit about that? I think I'm most interested in, what you think the consequence of this is, aside from, I think you bring out a very important one, which is maybe we're leaving innovation on the table that could help patients. Yeah. But I think there's a burden beyond that, this war of all against all, if you will, that you described. Can you talk a little bit about that burden and what that means in the real life practice of medicine, taking care of patients?
Yeah, well, this is the other side of the coin. If the future of innovation is one, this is, the access and affordability to medicines today for the patients and the ability of the practices to navigate this. And it's shown up in both domains. And so from the patient perspective, we recently completed some research with Ipsos on patients who had abandoned prescriptions. And what we found was that in this self-reported survey, 21% of patients reported having abandoned a prescription in the last 12 months, so 1 in 5. And the two top reasons were related to these issues. Number one was cost sharing, and number 3 was the coverage of their insurance, the formulary. And moreover, unfortunately, to your point, of the folks that had abandoned a prescription, 50% reported that their health had suffered as a result of that. So on the first hand, it's showing up in terms of declining access and use by patients who need the medicines. And then on the second hand, it's also increasingly showing up as tremendous growth in the friction of the practice of medicine and expense associated with navigating that friction. The AMA and others have recently reported some physician surveys where doctors are reporting, increasing burnout in the practice of medicine directly related to navigating these kinds of issues. And then my team recently published an article in Health Affairs trying to estimate the costs associated with navigating all this friction in the system. And it turns out it's a shockingly high number. In the US, we spend, probably between $420 and $500 billion a year or so on branded medicines. And we were able to document, just using very conservative data on things that have been written about and published in the last 10 years, which isn't most of this aggressive utilization management, and it's certainly not reflective of the more recent growth in it. But in any case, over $90 billion in estimated expense by health plans implementing it, practices navigating it, patients with excessive cost shares, and then manufacturers, as I mentioned earlier, standing up support services to try to help with the navigation. And unfortunately, of the amount that we were able to document, the lion's share was borne by patients, almost $36 billion a year in the excessive copays. So it's become a big problem. I think it is leading to innovation being left on the table in some of the chronic care conditions. And moreover, it is interfering with access and affordability today.
There are many different solutions that people have proposed, and things that have been tried, and some that have sit in a ditch in the side of the road. But I'd love your thoughts on the collective set of options that we should pursue as an industry, and what you think is the most promising. So let's go to the answer and not just the challenge.
Okay.
We're all waiting for you to tell us the answer, Scott.
Yeah, thanks, Ray. Well, in the short term, we're pursuing many of the things that, you're familiar with and involved in day to day, including that shift in our research agenda over time, to include more specialty, more oncology, rare diseases, cell therapy, and gene therapy. Novartis, plays in all of those areas today. And moreover, we're increasingly looking at the way we invest and develop our portfolio, not just individual products, with this notion of focused scale in mind as well. And like everyone, we're pursuing efforts to improve R&D productivity through new platforms for research and the use of AI. In many respects, if the industry could get a big uplift in productivity of R&D, that would be the most fruitful for everyone, really, solution to this. And then on the commercial side, we're taking steps to adapt as well. We've invested heavily in our managed markets capabilities over the last several years, in our patient services, in our use of data and analytics and the insights that those things derive, so that we can make better decisions about our business. And now we're focused on thinking of ways that we can enhance the productivity of each of our customer engagements. How do we improve impact with customers as well? But in the longer run, we're also, trying to generate a discussion, to your point, about some alternative approaches, Ray. As we've noted, we've got a system where we pay for future innovation based on today's revenue, and this creates a fundamental conflict between affordability today and the innovation of tomorrow. And, at the first level, what I'd say is it'd be useful just as a society to have an honest debate about this. How do we feel about that? Is that the right way to fund future innovation, given the way research and development has developed in the generic markets and all that? And if we say yes, that's fine, and we want to continue it, then it begs a question like, okay, well, but given the new economic realities, are there some things that we need to do to prop that up and ensure it's well functioning? And in any case, at Novartis, what we're asking today is, hey, is there a way we can encourage a shift from this system that encourages high prices, hidden rebates, and then intense utilization management and friction, to one that, as I mentioned earlier, that is the opposite. It turns out on its head and encourages lower prices from manufacturers, and then when you get them, better access for patients. And the important parts are really pairing the two conversations together and having a structured trade around it, a deal, if you will. And we call that value-based price for value-based access. But the notion would be, we want manufacturers to show pricing restraint. If they did that, and in this case, we'll say for argument's sake, in the form of value-based prices or prices that are negotiated around health technology assessment derived benchmarks. And then if the payer PBM accepts that lower price, that benchmark derived price, and says that's a fair price, then what we'd like to see is follow from that what we call fair access or value-based access for patients. But it'd be rapid formulary review in addition, no or simple clinical prior authorization, no step edits behind products that aren't fairly priced but have a big rebate, and fixed modest cost sharing for patients. So an incentive for the manufacturer then to provide lower prices, and then when they do, a reward, I guess, in the form of improved access for patients. And we think if we're able to do that, we could get lower prices on the one hand, we can get better access for the patients, we can get rid of much of this intense utilization management, decrease the friction for everyone, save a lot of money doing that, send better signals to R&D, and overall, for about the same amount of money, or maybe even less if you count all the expensive navigation that we're spending today, we can get more patients connected with the medicines they actually need.
Yeah, it's wow, it's such a intuitive and in many ways elegant idea, right? You've once described this to me as, the escalating war of cost and complexity, where the payer has to put up and step and all the complexities they create to restrict access to get a better price, and we put up all of the affordability program solutions and everything we do to manage out of pocket. And what you're really getting at is the heart of, what if we just didn't do either of those things and went right to the bottom line of what it needs to be, which is the right price and not making this hard for patients or practices. This kind of solution that you've proposed and you've outlined here seems like one that's durable and important in the face of, regardless of what happens in the public sector side, meaning this is the kind of thing that is in the direction of travel for our industry. We should put this in our crosshairs and go after it, even if we see policy changes in the nearer term or otherwise. Do you believe this is a durable solution, or do you think we have a lot to wait and see around the public sector, or should we continue to pursue market-based solutions like this in parallel?
Yeah. And they could be applied to any kind of medicine or any kind of patient, regardless of their insurance type. I think the policymakers will eventually decide to do whatever they think is best and whatever they think they need to do. But I also believe that we don't have to wait for that, that the private sector could choose to act on these things and could do it quickly if we wanted to. And really the key really is linking the pricing conversation with the access part for the patients, and there's no need to wait on that.
Yeah, that's great. Couldn't agree more. I couldn't agree more. So, a lot to do. There's a reality we have to live within today. We've got to navigate maybe changing the system in some of the pretty ambitious ways that you've laid out and your team has laid out. Where do we go from here? How do we, as an industry, take action, and what's that going to take? And what advice would you have for folks listening to this, navigating all these uncertainties?
Mm-hmm. Well, the first thing I would is just acknowledge that this is way bigger than our team at Novartis working on this. It's going to take multi-stakeholder collaboration in the industry, and I'll come back to that in a second. But in the meantime, we are going to continue to work on this with our team at Novartis. We're doing more research to continue to update and better understand the use and the effects and the costs associated with all this intense utilization management. We've got research projects looking both at the use of prior authorizations now and of copays as well, and the way those things have developed. We're also doing an actuarial analysis on this proposed value-based price and access trade. We've partnered with one of the big actuarial firms, and we're looking at several therapeutic areas with some different sets of circumstances to see, how the math works and how the trade holds up or doesn't. So we'll look forward to, developing the evidence base further and continuing to publish on that. We're also continuing to do stakeholder meetings. We are meeting with insurance plans, with PBMs, with a number of startup companies in this space that are, looking for new approaches and new ways to compete, I'll say. Also various patient groups who are keenly interested, in these topics, as well as, the medical societies and even some employers, Ray. Specifically, we're not talking to manufacturers, as you might guess, for the obvious reasons, the antitrust concerns. But that said, we do need to find other stakeholders, to our point, to my previous point, this is bigger than us, on our own. We do have some ideas. We don't know that they're certainly not the only ideas. They're not necessarily the best ideas. We want to, engage in a dialogue and educate ourselves and each other and see if we, can do better together. We're looking for folks that are, ready to try something different, to experiment and learn along with us. And moreover, the more we keep pushing at this, the more I'm convinced something's going to happen. There are just so many folks out there in healthcare, it's clear to me now, that agree that our current path isn't serving everyone well. It's not sustainable, that we need a change. And it's up to us as leaders in healthcare who care about this stuff to have the courage and to try to fix it.
If you put forward ideas and solutions, and you're very humble in saying these may or may not be the best, but at least they're ideas and solutions. And it impresses me as I look across the industry to see folks like you and you in particular and your team leading us and providing an idea and trying to rally the different parts of the ecosystem. This is not necessary to wake up and do every day to run in the current business, but it's absolutely necessary to make this a sustainable model that's good for patients. So I appreciate you being on, and thanks for the time, and let's go change it from the inside out.